third study, the CE-MARC-2, a randomized trial of 3 diagnostic strategies in patients with suspected coronary artery disease, and Professor Greenwood from Leeds will present.
Thank you, Fausto. I just need to get my slides on the... Okay. Can I get my laptop then, is it?
I don't see them.
No. Okay, good morning, ladies and gentlemen. I'd like to present the results on behalf of my co-investigators of the CE-MARC-2 trial, which was a prospective, multi-center randomized trial of 3 different diagnostic strategies in patients with suspected coronary artery disease, involving cardiovascular magnetic resonance versus the UK NICE guidelines versus myocardial perfusion scintigraphy. And this study was funded by the British Heart Foundation. Next slide, please. So invasive coronary angiography is commonly used early in the diagnostic pathways in patients with suspected coronary heart disease. And in fact, a large US study has reported that approximately 60% of those elective angiograms found no obstructive coronary artery disease at all. Our current guidelines for investigation of stable chest pain advocate management based on pretest likelihood of the disease being present. However, these pretest likelihood models can overestimate the disease risk and therefore can paradoxically increase the probability of invasive angiography even further. And we know that reducing unnecessary angiography should reduce patient risk and provide significant financial savings. So the purpose of this trial was to look at patients with suspected CHD and ask the question, is CMR-guided care superior to our national guidelines or to MPS-guided care in reducing the occurrence of unnecessary angiography at 12 months? It was a multi-center, 3-arm randomized controlled trial using a pragmatic comparative effectiveness design. And patients were eligible if they had suspected angina, were over 30 years of age, with a pretest likelihood of between 10 and 90% and suitable for revascularization. Sorry. This is a different talk, I think.
Somebody from the technical department here to check for the presentations.
Okay, next slide, please.
That's better.
Okay, that's it. Yeah.
Okay, so patients were randomized 2 to 1 to cardiovascular MR, myocardial perfusion scintigraphy, or the UK NICE guidelines directed care. And patients in the NICE guidelines group were scheduled for either cardiac CT, myocardial perfusion scintigraphy, or direct to catheterization, depending on their pretest risk. The primary endpoint for this trial was protocol-defined unnecessary coronary angiography occurring within 12 months, as defined by invasive FFR or QCA, if not possible. In 1,200 patients, they were randomized and recruited between November 2012 and March 2015. 265, or approximately 22%, underwent invasive catheterization, and you can see the breakdown between the 3 arms there, with about 42% in NICE guidelines-directed care, CMR 17%, and MPS 16%. But the primary endpoint of unnecessary angiography occurred much more frequently in the NICE guidelines-directed care arm at nearly 29% versus about 7.5% in the CMR and MPS care. And this was highly statistically significant when comparing CMR-guided management versus the UK NICE guidelines, but no difference between either of the 2 non-invasive functional tests. There was no penalty for detecting disease in that the positive angiography rates were comparable across the 3 arms. If we look at the sub-analysis of the secondary endpoints, we can see that the time to a major cardiovascular event within 12 months from randomization was no different between the 3 care groups. And if we look at the breakdown between different patient characteristics, again, the results were consistent irrespective of your cardiovascular risk profile, for example, your age, your gender, your presence of diabetes, smoking, etc., etc. So in conclusion, in patients with suspected angina, investigation by cardiovascular MR produced lower probability of an unnecessary angiogram occurring within 12 months compared to the UK NICE guidelines-directed care. There was no difference between the CMR and the MPS strategies, and there was no statistically significant difference between the 3 groups in terms of major adverse cardiovascular events at 12 months. Obviously, there'll be some important further data to come out related to quality of life and cost effectiveness for us to understand the additional clinical context of these findings. Thank you.
Thank you very much. Questions, please? First row.
Hi, I'm Michael Reardon with TCTMD. I had a question about there's a wide test, CHD pretest probability there between 10 and 90%. Would a patient that has a suspected CHD of only 10%, would they really be sent to the cath lab for angiography? And my second question pertains to the NICE and NICE directed guidelines. If you can just sort of elaborate on sort of what standard of care is in the UK, you can tackle those, either order.
So the NICE guidelines, as many other guidelines do, recommend estimating the disease pretest probability. And for the NICE guidelines, they say that if you're in the low risk group, which is between 10 and 29%, you should have cardiac CT. If you're in an intermediate risk group, between 30 and 60%, then some form of functional testing, such as MPS or CMR. And if you're considered high risk, so over 60%, then that group should be considered for a direct coronary angiography approach. So it's not like you were suggesting that we catheterize the low-risk patients. The guidelines are suggesting we catheterize the high-risk patients. What we've suggested here, what we've shown here, is actually, even when you use those models, perhaps you're driving more angiography than you really need to do, and you're creating more unnecessary angiograms. And this is really important from a patient perspective. This trial has been designed very closely with patient involvement at the earliest stage. And one of the key things that patients tell us is that they don't want to go through an unnecessary invasive procedure. That procedure carries a small risk, but it also, if it doesn't change their management, i.e. it doesn't change their treatment or their prognosis, then there's questionable benefit for that individual person.
Please, can you have the microphone again for the same gentleman?
Follow up again. In terms of the two methods that were selected, CMR and the MPS treatment, what are the theoretical advantages of the MR approach versus the MPS approach? And just sort of why was that selected as the comparator arm?
Okay. Well, MPS is probably the most commonly used functional imaging test worldwide for the detection of cardiac ischemia. More recently, we and others have shown that cardiovascular MR has a higher diagnostic accuracy, it's cost effective, and it also is a better prognosticator than myocardial perfusion scintigraphy. So the purpose of this to see was whether we could take what we now believe as the reference standard or the gold standard functional imaging approach and now challenge the UK guidelines head to head in how we manage patients and look at the outcomes as a result of only doing a cardiac MR across the board in all of those patients versus this risk stratified approach of different management arms.
Any other questions, please? First row.
Mitchell Zoll, Cardiology News. The MR is done with what kind of device?
It's just a standard clinical MR scanner.
So 1.5 Tesla, 3 Tesla, it doesn't make a difference?
This study was performed at 3 Tesla, but we've done other studies at 1.5 Tesla, and really there's no firm evidence to say that one field strength is superior over the other. So it can be done on any clinical scanner as long as you've got some basic additional cardiac software.
So it does take additional software to do this. And, pardon me, how ubiquitous or not these days is that kind of MR device?
It's, as you say, ubiquitous now. I mean, if you look at the UK and Europe, cardiovascular MR now has proliferated and is used as a first-line test clinically in a large proportion of patients. What we're seeing at our institution and other institutions across the UK is that there is a continual shift, if you like, a migration towards using advanced cross-sectional imaging techniques from some of the older technologies such as MPS.
And could you also address, we heard another paper in this group that was using CT angiography for sort of the same purpose, I guess, for the same purpose. So how would you see CT angiography and MR comparing?
It's a really good question, and I think we don't understand or we don't know the answers completely about this whole debate around anatomical testing versus functional testing. What we know from CT is that it's a really good rule-out test, perhaps in low to intermediate risk. But actually what we're more interested in the intermediate to high-risk patients is being able to detect the evidence of ischemia, because it's by potentially treating ischemia that we can alter their prognosis and outcome. And to be able to do that, you really need to do a functional test, whether that's cardiac MR, MPS, stress echo. So I think what we're saying here is functional testing is really important because it's functional testing that detects ischemia, and it's ischemia that we treat as cardiologists.
Any other questions? Please.
Just briefly, Melissa Walton-Shirley, was the 7.5% of the CMR and the 7.1% of the MPS anticipated false positive per your usual findings?
Well, it's not the true false positive rate, because in this study, not everybody got an invasive catheter. It's only about 20% of the study population. So you can't actually say what the false positive and false negative rates are. But I'd refer you back to our original publication in The Lancet in 2012, where we did a study of 750 patients and mandated that every patient had every test, whether they needed it clinically or not. So every patient had an MRI, every patient had an MPS, every patient had an invasive coronary angiography, and the results of that are clear in terms of the false negative, false positive rates, sensitivity and specificity, positive and negative predictive values.
Thank you.
Any other final question? Okay, thank you so much. And
Thank you.